Today's webinar, Unleashing the Potential of Virtual Care to Enhance the Patient Experience. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. First, we'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a Q&A session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Second, if at any time you don't see your slides moving or are having trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box, and we'll be here to help. Third, we'll have a series of poll questions during today's webinar. You can submit the answer that best applies to you directly on your screen in the slides box. And we thank you in advance for your participation. Lastly, to learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. And with that, I'm pleased to welcome today's speakers. Ruth Colby is the President and CEO at Silver Cross Hospital. She previously served as Senior Vice President and Chief Strategy Officer for 12 years. Rich Steinle is the CEO at Carrion, where he is responsible for stewarding the company's people, story, and growth. Ronel Sinus is host of the Ramp It Up podcast, where he shares his personal recovery journey and highlights stories from the spinal cord injury and disorder community. Along with that, he is a lead assisted technology trainer at the TSF Foundation and a digital accessibility tester at Fable. And Julie Wilk is Chief Marketing Officer for Carrion. Before that, she led global workforce transformation and leadership development initiatives for Dell Technologies. Ruth, Rich, Ronel, and Julie, thank you all so much for being here. And Julie, I'll now turn the floor to you to kick off today's discussion.
Thank you so much, Carly. And we're so excited to have everyone here. And I couldn't be more thrilled about this panel. I was messaging with some people online on social media this morning, talking about some of the conversations that we're going to have. And I know some are going to join last minute because everyone knows sitting here in strategy season for healthcare. So this is a timely conversation, one that's going to sit directly where we need to have as an experience to be within their daily life. And that's where the role of virtual technology comes in. So without further ado, we're so excited to jump into the conversation, but we want to start first with our audience. So we're going to begin with a poll. And this poll really sits at the center of strategic decisions. What are your competing priorities outside of patient experience? Because we are realists, right? As much as we know we want that patient to have that beautiful white glove experience, we all know as leaders as well, there are other things also at that table when we're having those hard conversations. So from everyone in the audience, if you will please answer the poll. We have several different options for you to consider. And these are ones that we hear as leaders the most often: reducing costs, mitigating staff shortages, relieving staff burnout, consolidating your tech stack, or reducing readmissions. Which of those feel like it resonates for you? So as everyone's taking a look and answering their perspectives on this, Ruth, do any of these resonate with you as a CEO of a wonderful hospital?
Thank you, Julie. I'm looking at this list, and I probably would check every single box, as most of the audience would as well. But when you think about it, they're all related to the patient experience. If we don't reduce costs and aren't able to, create a patient experience, certainly, especially as people have more and more responsibility for paying for healthcare, it's important. But, when I think about the patient experience, it's not a maybe, it's not a nice to do. It becomes absolutely the top priority. I mean, healthcare is about people taking care of people. And, if you start from that viewpoint, the rest of the priorities really all fall in place behind that. And at my hospital, everybody is responsible for the patient experience. We have cascading goals that start with me, every housekeeper, every person in the business office. No matter how anybody communicates with the patient experience is top of mind. And we share those goals, and the goals are in our strategic plan. We always have patient experience goals in our plan. Probably our best ideas in how to improve the patient experience comes from our staff. So we listen to them all the time. But I think even though we have all these other pressures in healthcare, that the consumer experience is not a nice to do, it's a must do. And, as we continue the conversation, technology can play an important role in that.
Oh, I love how you really wove in that idea that, patient experience and then with their trusted provider, and really knowing that the front line has that touch point to it and really listening to that. I think that's wonderful. I know Ashley, who's one of our producers, put up the results on this. Does any of this surprise you, Ruth, as you're looking at that and thinking of, no?
No surprise. I mean, staff shortages is a problem everyone's dealing with across the country. And it's not just healthcare. It's really many industries are suffering with this. And then the burnout issue is related to staff shortages. And I'll add to that, we're seeing violence inside hospitals these days, which increases burnout and reduces the number of people who want to work in healthcare. So, no, I'm not surprised at all. And certainly at my hospital, mitigating staff shortages and staff burnout are the very top things we think about through wellness programs, through health programs. I can talk about something we're doing with Carium, employee health, in a few minutes. But no, these are extremely relevant to our workplace today.
Yeah, and I wanted to bring up one. So, I mentioned on social, I was promoting this webinar, and I invited people, if you had a question, to come in to just direct message me and let me know. And there was one that came in that's related to this, and I'm just going to throw that one over to you. It says, what advice would you have to avoid falling into the trap of just focusing on those short-term urgencies or fire drill priorities, as we call them, versus what's really best that serves across the competing priorities, especially in relation to patient experience?
Well, that is a very interesting question. I never think short term. I mean, you really have to take the long view. And again, it's through strategic planning. So our strategic plan looks out probably more specifically 3 years, but we push out to 7 years. And that allows us to prioritize what's most important and not just do, a quick, this is the color of the week or something like that. Sometimes we have to adjust quickly. And certainly we learned that through the pandemic. We learned that we're capable of it to be able to adjust quickly. But we always take a long-term view, and patient satisfaction is at the top of the list, no matter what new initiatives we're doing or what we're launching or how we're communicating with people. That has to be first and foremost in our minds.
Excellent. Ronell, since Ruth really set the stage of what it looks like from a leader of a major hospital, of what are they talking about, let's now look at what your perspective is as a nationally renowned expert and patient advocate. What, in your personal experience with virtual healthcare, what do you think are the drawbacks? What do you think are the benefits? What is it that you're noticing from your particular network?
Yes, thank you so much, Julie. So for those that may not know, I am a C4, C5 quadriplegic, and with paralysis comes many challenges, mobility, of course, being the first, and transportation to and from appointments, and depending on where you live, whether it's a larger metropolitan area, somewhere more rural, you may not have reliable transportation. So adding virtual appointments and some of the telehealth has really allowed, especially during the pandemic that we went through for these last 3 years, have really allowed a lot of the patients to still interact regularly and during emergencies with their primary care physicians and their specialists, and they were able to get crucial information to their insurance. So it was an amazing opportunity, especially when many people were afraid or unable to attend a lot of these appointments in-house, in person, or in brick and mortar. Unfortunately, of course, just as every new innovations comes, there's always a downside as well. As again, a quadriplegic man, being in person, being having that face to face with my primary care physician is extremely important, because they are able to do, when they're doing checkups, they see pressure areas that I may not be able to feel. Something as simple as getting your weight checked. Things like that are being neglected because many patients and even some of the physicians are looking to, I guess, increase those telehealth appointments. So as much as it is more convenient, and I'm very grateful for them, and sometimes when the insurance wants you to get a quick visit in, so that video call comes very much so, it comes in handy. You don't have to get into transportation, get someone to go along with you and spend 4 or 5 hours in your day. You have just a quick 30-minute call and you get everything taken care of. On the other end, there is this innate concern in the community that they're going to move more and more towards this telehealth, and we're going to miss the real important face-to-face interactions and getting that hands-on, because again, there are certain times where my physician may not have seen me for 6-7 months, so they may not see some of the regular changes that may happen in my body through the camera alone.
Mm. Julie, can I jump in here now? Thank you so much for sharing. Yeah, thank you for sharing that. And, I come from this place of thinking we always have to meet people where they want to be met, right? And I think that's what you just described. I mean, sometimes you want virtual care and sometimes you want personal in-person care. And how do we marry the two? And it's going to depend on what an individual desires.
And I'm very happy to hear you say that, Ruth. It has to be a combination of the two. And I think giving the patient those opportunities to choose for themselves. If it's just a regular checkup, I have no problem seeing my primary care physician over, or even a therapist or someone just when they're having a quick conversation over, a telehealth, a Zoom. That's perfectly fine for myself. I just need to refill a medication. But if I haven't seen someone in person for about a year and I want to make sure, hey, pressure sores are being looked at, or, I want to make sure I haven't gained or lost too much weight, things of that nature, you need to have that face-to-face in-office presence. And not only that, but just for the care provider to get a better sense of who I am. Because unfortunately, when you're not in person, you miss out on a lot of the cues that you may see while I'm in the office.
Yeah, I think, Julie, if I may jump in, both on the first thing you showed, Ruth, when you put the poll up, and I heard you chuckle, Ruth, it almost seems like you can't pick. And, I look at all of those things and we hear from our customers all the time. I've heard it from Ruth as one of our customers. That's almost like a prism that everything has to look through, all of those things. We don't get the privilege of saying, which would you like to focus on, Ruth, your staff shortages or the burnout, or would you like to cut costs, right? Or would you like to put more in the hands of your patients and have them have a white glove experience? Because the answer is all of it. And I think what Ronell just said is the same thing that we hear in the market is there has to be an innate flexibility to all of that. Healthcare tends to want to move in big, big monolithic swings. So is it in person and brick and mortar, or is it all virtual, or is everything democratized out to them? And the answer is it isn't. It's meeting the patient where they are. It's meeting the delivery facilities where they are. And it's all of those things. And so that's certainly the challenge we keep hearing from the market, and, the challenge that I hear from my friends here today.
Yeah. And, to build on that, I think people, at least what we've heard from our patients here, we're outside Chicago, is that if there's a trusting relationship to begin with, then there's more trust in a virtual option. Mm-hmm. Is that, Ronell, would you agree with that?
Oh, 100%. Like my primary care physician, I've been with her for like the last 5 years. And it's because when I know I'm in office the staff, they know me personally, and she's been amazing. So we've built that relationship. We've built the trust that when I'm just over a quick call, I know that she's going to get what I need to get done, and she understands some of my complications. And she'll tell me, she's like, well, I haven't seen you in person in a while. Next appointment, I need you in the office. We can make sure everything's good. But without having established that relationship and that trust with her and the office staff, the nurses, and everyone else, I would not have felt comfortable doing so. And just to kind of piggyback off of what Rich was saying, it's also important to understand the community that you're working with. Myself, because I advocate so much for the disability community, you have to understand there are patients who are a bit elderly who may not be comfortable using telehealth. I know my father, he's in his late 70s. I couldn't even try to get him to start using Zoom for a doctor's appointment. And not only that, he does have a more of a older school mentality where he needs to be in front of the patient. There are other persons with disabilities who may not be able to leave the home as easily, so it's better for them. So understanding who you're serving and who your individual patients are really makes a difference.
One of the things that this is really pointing to, as well as another one of the questions that came in this morning when I did that outreach, and it really centered more on hearing what Ronell says and what Ruth is saying. This one's really for you, Rich. How is it being with a healthcare technology company? Is it that the solutions and engineering teams are really thinking about things such as Ronell or Ruth when they're coming down into the development process? Because the sentiment that was shared with me this morning is that some of the technologies are not really very patient focused. It's more engineering and a silo focus. How would you answer that?
Sure. I would say if we're not focused on Ronell and Ruth and everything that you just heard, then we're not doing our jobs. And we're certainly not listening. One of the things that I say the most in clinical and technology circles is if we do it right as a technology platform, you won't see us or you won't hear from us much. I think the best technology is the least imposing. I think it fades to the background. The way I like to think about it, the way I challenge our engineering teams is, does it put more of Ruth forward, right? Silver Cross is what has to reach her customers. The way they do things, the relationship she's already got, the trust that she has in the community is what has to be put more of, better of, further out. And so that's the challenge to Carium if we're going to serve her, is more of Ruth, more of their medicine, more of their trusting relationship in different media, in different hands, right? More of it. And Ronell, to me, gave the perfect example. He doesn't want a different experience with his primary care physician, that he's developed that. He may want a little more of her. He may want her in a little different setting, may want her a little more, immediately accessible. Those are the challenges that Carium and other technologies can focus on, right? Is how do we bridge that even more? How do we really light that relationship, even further, enable it even further? And it goes back to the other questions too. How do we help burnout? Make it easier. How do we help staff shortages? Make Ruth need less staff, right? Those are the things. And if we don't take on their challenges, their desires, their problems, their strategies, then we're just building technology for its own sake. So we really try to stay away from that.
I'm sorry, Julie, if I may just.
No, you interrupt me anytime. That's your job, so go for it.
Thank you so much. Just to kind of jump on the side of Rich, I'd be remiss as an accessibility tester not to talk about technology. What we tend to bump into are these amazing technologies being developed and these innovations, but unfortunately, they're being put before the population that they're designed to work for. I can use myself in case, I'm using different portals online, and I tend to be very technologically inclined, but that's not everyone. So as a tester, what we're asking some of the developers to do is during the conception process, before these products are almost finished, contact your community that you're looking to serve. Get people to test your products, see how well they work out. I have mobility disabilities, but but they may not work for someone else who may have visual or auditory needs, or even someone with developmental. So having them to be tested out on the different communities as much as possible, understanding, even the elderly community. Again, speaking for my father, who's just now understanding his iPhone, he wouldn't be that great on one of the platforms. So, being able to test and it'll not only prove that these technologies work well for the disability community, but many times for the broader community as well. It'll help someone out who may just be having their glasses not working well today because of someone else who has vision impairment, or someone who just has a louder background. Well, because they've tested it out on folks with auditory issues, it may work out better for them. Or someone may have just broken their arm for that week and can't access touch screen. Well, now that has voice control, because of someone like myself with mobility issues, it now works out for the broader community as well.
If I can build on one thing that Rich said about technology being in the background, but I would add to it, and I've experienced this firsthand with Curium, developers need to make it easy for us in the hospital world and for providers and physicians who are delivering services. And certainly that can help with burnout. But it needs to be easy. The interfaces need to be easy to do. We don't have enough resources to have a huge number of IT people here. And, when Rich and I first talked about this and he told me that he can make it easy, I'm like, yeah, sure, show me. And you did. You did. So I think that's also something that's really important in the development of technology. Make it really easy, not just for the patient end user, but for all of the providers as well.
Yeah,
go ahead.
I'll just say one more thing on that. One of the biggest things we have to do as technologists is not fall in love with more. And realize that less sometimes is the elegance. Something Ronell said about his father makes me think of, I was just with clients in a developing country. And 5-10 years ago, one of the biggest challenges with virtual and remote technology was the proliferation of smartphones. Were they in hard to serve areas? Were they in economically disadvantaged areas? All those kind of things. Now they're not really a luxury anymore. Everyone's got them, including most places in the developing world. But here's an interesting thing. In the States, one of the most urgent elements that we needed to add to technology was embedded video. It's just one example, right? I don't want to go to a separate app. I don't want to have a separate technology stack, anything like that. The minute we were in the developing world, they said, everybody's got a smartphone. Nobody uses apps. Now that doesn't even make sense in this environment. What do you mean you don't use apps? And the answer is we don't. What do you use? WhatsApp. It's the only way. So all of a sudden delivering healthcare via WhatsApp is decades ahead. You got to be able to do less and deliver more. You have to. And that's hard for technology companies. We fall in love with what's next. We fall in love with what's more. A lot of times, the ability to strip it down, the ability, again, just listen. Just listen to what Ronell just said. Meet him there. That's the biggest challenge, I think. We have way more technology than we need. The answer is listen and meeting.
Yeah. I love that less is the elegance. I think that is such a wonderful statement. I want to circle back to something that you were talking about as well, Ruth, within this context. And you were talking about, making it easy for your team at Silver Cross Hospital. That technology has to be easy. It has to seamlessly be able to work within the ethos that you have. However, we all know that people fear change. They have a strange relationship with change, and that change management, regardless of how savvy your strategy is, even when it's laser focused on all the beautiful things of patient experience, things can go awry pretty quickly. So what are you noticing in terms of the shifts that you're having to make in order to integrate, virtual technology so that it's not, there's another thing we have to do, and it just makes things worse?
You know, I could talk about this for probably about hours and hours and hours, because you're right, change is hard. And when you want to bring forward change, you're really talking about changing people's hearts and minds. And we always go back to the what's in it for me. And I'll give you just a quick example. Our organization is struggling through bringing Microsoft 365 into use. And I know we're really late on this. Others have done it years before us, but the barriers to change are really hard. And you have to be able to do the change in small increments and celebrate the wins and get people, ready for what's next. Because otherwise they will bury their head in the sand and not want to participate. One of the things we've seen is, and this is in relationship to our role with Carium, is many of our patients were not interested in using technology in terms of taking care of their heart failure issues. But once they built trust with the provider, and that provider introduced the technology very, very slowly and helped people through it, then it became a tool that people really adapted to easily. So it's all about how much change can people take at any one time. And you have to be able to measure that constantly, because change in healthcare is just the status quo. It is all about change. But if you overwhelm people with change, they'll hunker down and then nothing happens.
So what are you, for anyone who's out there is like, oh, Ruth, I'm right there. We struggle with change management in our healthcare organization. Do you have a suggestion for them? I know you said to break it down, to make it small. Is there anything when you're talking with your leaders that you found that might be something very concrete that you could share that might help them through a change management, especially when we're looking at adopting a technology?
Yeah. I always go back to getting to the what's in it for me. Maybe that's old school thinking, but I still think that's really important. So identifying, what's in it for an individual and what are people afraid of? And change is usually about loss. So when you sit down and think about what is somebody losing, and then what might be the gain for that is, adaptive leadership is what it comes down to. And that's what we try to use here. But what's the loss that someone's going to suffer? Somebody who is really good at sending emails with attachments and it's easy, versus sending something with a link to, a cloud-based system, is a big change. And it sounds easy, but it's not. It's understanding how hard it is for people to adapt to something new. I don't know that gives, a to-do, an easy way to think about it, but I think most management teams are trained in adaptive thinking and what it means for their teams.
Excellent. Rich, I know that, you've had such a long career and wonderful career in technology. What would you say that you're seeing in your conversations in terms of, to follow on with this, are there anything that you're seeing of success or anything that you could share to help anyone in our audience as well? And I invite our audience, ask questions of anything that we're saying. If you too are struggling with your strategy, with your virtual health strategy, about reaching your patients, about being able to retain patients, anything related to this, put it in the Q&A box. We really want to be able to hear your questions and answer those. And so, Rich, to this point, what are you finding with customers in their own change management in adopting new technology, particularly virtual health, shifting from that traditional kind of telehealth model into something more advanced?
Sure. Thanks, Julie. Yeah, I think a lot of it comes down to, as Ruth sort of started with, she talked about taking the long view. She talked about strategy. Now that's something that, I've appreciated about her as a friend for a long time, but that's hard to do because long-term view makes tough short-term decisions a lot of times. And so I think as I speak to leaders around the country, there's a lot of pressure right now about prioritization, making decisions when you're in fiscal crisis as an example, that cost more is that's a seasoned leader. That's
Right.
adaptive, as Ruth just talked about. So there's a lot of questions about value. That's one of the things that I would say. Return on investment, I hear all the time. You can't make something that costs more cheap enough for someone that's in a fiscal crisis. It has to be about what it does longer term to the organization. It has to remove long-term barriers to care. It has to remove long-term cost levers that are going to grow. There has to be an investment mentality versus a cost management mentality. So I hear a lot of that from leaders. We're certainly challenged to work all of our deals into that sort of frame. And that's, that's something that I enjoy because I was a management consultant before I got into healthcare technology. But you really have to go there. So you have to understand their business. You have to understand what they're trying to do long term with it, versus just sort of price control. And I think that's a lot of what the most innovative leaders are looking at, is not even what's next, but what's way down. And realize that what they're dealing with right now are crises. And that's a tough environment. And so we're trying to help in that. We're trying
It
to
is
go
exhausting.
It is. And, to make a decision in our case, Ruth invited us into her 7-year strategy. You heard her reference it at the beginning. And so that's what I think you have to do. And I find that with every organization that we serve, whether it's a startup that has a scarce budget, or whether it's a large organization that's in these staffing, human resource, fiscal crises, that some of which were dramatically exacerbated by the pandemic, and then coming out of those. So I think that's what we're hearing. That's what it's about. There's a dramatic scarcity environment right now, while people are trying to make very strategic decisions about the future.
One thing we haven't touched on, and I think it goes back to the topic of trust, and Ronelle, I'd be very interested in your thoughts on this, is cybersecurity attacks are more frequent than ever in the hospital world right now. And we all talk about it as, when it's going to happen, not if it's going to happen. But from the technology perspective, Rich, what are you doing, or what are technology companies doing to help us with to be safe places to use virtual? And then Ronelle, what do you worry about when you're using technology and the fear of cyber attacks?
I'll let
Ronelle, we'll let you go first.
Okay, me.
Yeah,
Okay.
Go ahead.
As the user, of course, since the majority of us are all holding our smart devices, and like for myself, I have at least 2 portals on my phone, and the iPhone has its own health app. So many of us are concerned that, one, you're giving away too much information at first. There are too many apps that have too much access to all of your personal information. I'm not the biggest conspiracy theorist, but I'm like, there's way too many apps that know too much about me going on all at the same time. So I do believe there needs to be a way to, one, consolidate as much as we can. I don't want to have, like, I go to Memorial Hospital in my area, and I'm like, okay, I'll have the Memorial app, but then there's the MyChart app, and then there's the health app, and it just feels like so much of your personal information is open and accessible at all times. And then when you're in the hospital, there's your chart there, and there is a concern that it's too easily accessible. Now, the positive side is when, let's say, I needed to go to a different facility, there's the ease of information trade. But I think there needs to be some sort of reassurance to the patient, to the user, that my information is safe and I shouldn't be as reluctant to input it, and that not everyone has access to it. I can pick and choose who can see my information, whether it's a care provider or a social worker. It's not just every person that may have access to the system, or those who are looking to do illegal activities who can easily break into the system.
Yeah, I think, Julie, I would piggyback on that and say that the type of things that tend to be easy for technology, putting more data in more hands, more accessible, more easily accessible, more timely accessible, that we tend to get excited about and even brag about, scare people if in the wrong context. So exactly what Ronelle said, when you tell a care team, hey, I can increase your touch points with your patient in a particular disease state 100 to 1 over the course of your normal year, we think that's great. Immediately you do that to a care team and they say, whoa, what's the liability for that increased amount of touch? What happens if I don't respond right to every single one of that piece of the piece of data that's coming in? What happens if no one's on call when that alert goes off, right? All of those kind of things. So I think you got to be sensitive to what you're enabling, and really understand that. Same with the patient. I'm putting your data so much more accessible. What does that mean? In more hands, in more places, just like Ronelle said. And so I think you have to be sensitive to that first, and then you have to make it a massive priority. You have to make security and care a massive priority. We took an over-the-top approach to that on the back end of our systems, so that, again, the heaviness is invisible. But, when I say Carium's had 0.0% downtime for anything other than scheduled testing in the entire history of the company, it's only because the architects made it an absolute priority. It's never happened. And we have to be able to tell that to patients, and we have to be able to tell it to people like Ruth. And then we have to prove it. But then we have to be careful with everything that we can enable is not always the thing they want most, right? So there's your less is more again. We can, should we? In the right time, in the right place, in the right hands. That's how we try to deal with security.
And if I could jump back in, I think that just goes back to what we were speaking about before, understanding the community that you're serving and asking them prior to doing the final stages of these technologies, asking, hey, how do you feel about this person having access? Like, again, going back to some of the apps that I have, they ask permissions. Are we allowed to connect these two apps so we can make sure my specialist, which may be with one hospital system, is okay with my neurologist having this information just for ease of information? Being able to give that permission versus it being taken out of my hands and just finding out that everyone knows everything it is where it's a little scary. Now, the fact that, okay, hey, Dr. Bill is asking Dr. Gina, is it okay that Ronelle sent, that makes a big difference from the user perspective. And again, we're not going to run into security risks. We're not going to run into patients avoiding using the technologies because of their own skepticisms.
Yeah, no, that's true. A great example, I get a ton of questions about the different sets of caregivers that surround a patient. And that's very variable by culture, by geography, by all kinds of things, really, by income level and all kinds of demographic elements. So, one place that says, hey, you know what, the local parishes are some of the main deliverers of care. We have these teams that wrap around people in the community, and they're their transportation and their meals and all these kind of things. Can you expose the data to those people? Now, my yes in that environment would scare another environment to death, right? And so I have to be able to modulate those things and say, I can lock it down here. I can open it up to the hands that you choose. Just to Ronelle's point right there, listen to what they need. Can I give it to everyone around, the 5 people that need it around you and no one around you? Sure, we got to be flexible enough to do that.
Right. You bring up a really good point. And I want to bring up our next poll, Ashley, which I think really does actually tell very nicely to your last comment, Rich. And it talks about health equity. And what are the barriers you're experiencing in regards to equitable access to virtual care within your community? We put a few up here. We know there could be many more. Unfortunately, we didn't have a write-in option, but we chose the top ones: connectivity, health literacy, tech literacy or language barriers. So if you would, in your poll, indicate what barriers you're experiencing. And as we answer that one, you know, I know, Ronell, you mentioned a few at the beginning when we're talking about some of the barriers. You've mentioned, you know, really looking at the age of the person. Are they tech shy? Are they tech savvy? You know, wondering how that is. What actually are their abilities, and can it marry in well with those abilities, or does there need to be a different solution? So I would really like to ask you in terms of what other barriers are you seeing as well? So Rhonda, I'm going to let you start in terms of anything within virtual care within your community.
Of course. Thank you, Julie. So again, living in South Florida in Miami, we have a very unique population here. We have folks like myself who are of Haitian descent. We have a large Hispanic population. So one big thing is the language barriers. I was very glad to see it here on D. I live in a community that's not too far from where Hialeah is. So my providers may come here. I have a caregiver sent to my home that'll speak no English. And that is an issue right then and there. And the misunderstandings are, especially in a virtual situation, trying to translate it. A lot of the apps may not have Spanish or Creole option, or just a Spanish option, and I may have someone that speaks only English and Creole like myself. So that is a huge barrier as far as dealing with that. But another one is, again, we have an older population. South Florida is, you know, known for a lot of folks who are coming here for retirement. Switching over to technology is, for one, not only scary for them, but they may not know much about technology. I keep speaking about my father, and hopefully no one tells him about it, but he's not the best when it comes to tech. He wants to be in front of a provider. He wants to hear what they're saying. Even when it comes to setting appointments, they're telling you, okay, well, go online or check it online. And those things, if I'm not doing them for him, he is completely lost. Even something as simple as sending the prescriptions in digitally, whereas he grew up in a time where it was paper prescriptions that you were handed and you're bringing it directly to the pharmacy on your own. So again, understanding that if your facility, your hospitals we have a older community here called Century Village. If you're across the street from Century Village, don't expect the folks there to be so excited about virtual appointments. They want to, for one, a lot of times, that's the only time they get out of the house. So that's their social day where they may go and hang out with friends or go out to eat. So now you're removing not only their social time where they're connecting with other individuals, but you're now complicating it with technology that they don't understand. It's a frustration. And that may lead to them, again, choosing just not to interact at all, choosing to skip appointments, and that will affect their health as well. So again, very happy to see some of these options appear. I wish I could vote. I'd vote for all of them.
Mm-hmm. Ruth, what about you? And I'll have Ashley go ahead and show the results with this, really looking at those barriers to virtual health technology. And have you been able to overcome any of those barriers at Silver Cross Hospital?
Well, overcome is probably not the right word, but I agree with the poll, although I probably would have rated health literacy higher than tech literacy. At least in our community, we've seen people more facile with tech because of the pandemic. But to that end, we do a community needs assessment every year, and we have places in our community that absolutely do not have access to internet services. So one of the things we did is partner with AT&T, a local internet provider here, and we got a grant so we can bring internet services to people so they do have access to virtual care. So that's, a barrier that we're trying to reduce, in that people may not have been able to afford it, or, and we're able to help them with that. So that's one. I mean, another thing in health literacy is very connected to some of these social determinants of health that are so important in underserved communities, and really understanding, why there's such differences in outcomes. And we spent a lot of time in our community about this. Let me just give you one example where technology's played an important role. Is we've identified not just food deserts, but households, specific households that don't have access to food, may not have transportation to go and get food. So we've been using, and we work with the Northern Illinois Food Bank, and we provided technology that people can order food with through the Silver Cross app and have it delivered to their home. Healthy food that they might not be able to get otherwise. So I think technology can help us a lot with that. I mean, we have lots of different languages spoken in our community. We have language lines that we use here. It's very important to be able to do, interpretation the right way. So technology's helped with that, but that's been around a long time. So I worry about health literacy and people really understanding how to take care of themselves and what access to resources that they have and perhaps don't use.
Excellent. Well, I know that
I'll say, if I had a quick second, just to add to what Ruth was saying, I was so excited to hear when you brought up the grant, which kind of gave birth to the grant I'm currently working on through the TSF Foundation, because it's one thing to have these technologies created and virtual and telehealth, but it's another if the user is unable to use them. Like myself, I have mobility disabilities. So we found that there's missing folks who need assistive devices to access technology. Again, whether it's hearing impairment, mobility, or vision, they need assistive devices like I'm currently using to access my computer. So just because telehealth is available, if I don't have my caregiver along with me, I may not be able to access that appointment. So having grants to actually make sure those deserts, as Ruth was saying, are covered, where they're receiving the technology, whether it's the connectivity or the actual hardware to connect, is extremely important.
Excellent. Well, Carly, I know that you are itching to come back on your audio because I noticed that we have a few questions coming in. As much as I know that all of us, the three R's and Julie, Ronell, Ruth, and Rich would love to keep talking. We really want to hear those questions. So Carly, I'm going to kick it back to you.
Excellent. And thank you for such a great and informative presentation. Our first audience question is, are there any suggestions on the implementation of inpatient virtual care, such as virtual nursing, to enhance the patient experience and relieve burden to the bedside nurse?
Well, I suppose that would be me. I'm watching this very carefully. I know there are hospitals that are doing this. We are not at this time. I tend to be somebody who watches advances like this and then jumps on the bandwagon once I see proof that it's working. I think it's a great idea. Again, adapting to change. There are nurses that think that it's absolutely crazy. And although it may reduce the burden, I've got to get our team to the place where they're comfortable with it. So I'm watching it carefully. Unfortunately, I don't have suggestions, but I think it's something that we all have to look at. And it's not just, relieving the burden. Many of our, the nurses want to work from home. They might have childcare responsibilities, other responsibilities. And if they can do a 4-hour or 6-hour shift from home, that can save them a lot of time. But we are not at the forefront of this right now. I think it's extremely interesting though.
Thank you. And our next audience, sorry. Sorry about that.
Go ahead. It just really gives a nice sound effect to the healthcare tone we have going on. So just keep going.
Yeah, our next audience question, is it possible to use a solution from Carium both inpatient and at home?
If I heard that right, is it possible to use a solution at home and in the hospital? Yeah, the short answer is absolutely. That's exactly the way it works. There's and a lot of the implementations with hospitals deal with both. It's remote, it's in the facility, it's sometimes in a perioperative setting, it's pre-surgical, during all of that, and then taking it home to the patient. So again, it's really customized to the workflow. in the hospital. But absolutely, it allows the care team to interact with the patient and their family or circle of caregivers in and out of the facility. One of our largest hospital clients uses the phrase, "It allows us to never take our eyes off of our patients," and they find that of great comfort.
Excellent. And our next audience question: what workflows are being used in the acute hospital settings to show most value today?
Oh my. That's I'm not sure we can tackle that right now. I don't know, Julie, if you want to jump in, or Rich. I mean, there's so many different workflows. I think a real quick answer is making sure that our teams are working interdepartmentally rather than just in silos. And I know that sounds like a very old school thing, but still the way we're set up and many other hospitals are set up is that teams don't necessarily work across departments. And the more we can use technology to do that well, and the more we can set goals so that people want to work together, is something that we're concentrating on very hard at SilverCross.
Yeah, the only thing I would add to that, I mean, rather than just running through different service lines or, chronic disease states, which you could imagine probably the ones I would say, I would just piggyback on what Ruth said, and to say the things that we're doing that are delivering the most value tend to be the more complex and or the more repetitive, the better, or the more value, right? So if someone like Ruth comes to me and says, I've got this massively complex process and I really need to take it out of the hands of people that it's straining my workforce, that's the kind of thing that we can really bite down on and really solve for someone. So, huge administrative workflows that then move into the clinical, we're really able to say, let us take all those things that technology can do, we'll automate all of that, and just keep those clinical interactions that we can't do, that only you can do. And that's the way we're working best together. So I'll just add that one piece.
All right, thank you. Our next audience question: how can virtual technology contribute to preventative care and early diagnosis, potentially reducing the burden on hospitals and improving patient outcomes?
If I may jump on this one. First and foremost, the wait time for appointments has gotten to be from 2-3 months to 6-7 months. So allowing the patient to connect virtually with their provider shortens that amount of time. I may have a concern now that'll be exacerbated in 6-7 months, but if my doctor tells me, okay, I could see you next week Tuesday at 1:30 p.m. on your phone, oh, that is so much easier. It cuts out the need for transportation. It cuts out that wait. So whatever concerns I have now won't take that amount of time, won't be exacerbated, won't have time to, just get much worse. And it's giving me that interaction, because even if I may not see her face to face, now that I can send her a message through the portal, send her an email, send her photos like, hey, this may be a pressure sore. What do you think about it? Even though we haven't had an official appointment, a time to come in, she can address it. She can say, hey, in the meantime, take these measures, or they can send home health. And then when they have that appointment in person, go ahead. Or she can tell me, hey, you may need to see someone at the ER to take care of it, versus me waiting. Okay, I have to wait over the weekend or a few weeks to get something that could have been handled within 2-3 minutes, especially if it's prescription refills or things of that nature that we don't have to physically be in person to do.
Thank you. And our next audience question is, as we explore virtual solutions, how can healthcare organizations maintain transparency and foster trust with patients in their digital healthcare journeys?
I think this goes back to the conversation we had about cybersecurity and being able to trust the developers and trust the hospitals and providers that we're doing everything possible to protect patients, and so that their records are not hacked into and none of their data is compromised. I think most of that. Do you guys agree that we covered most of that?
Completely
Yeah,
agree.
completely. Even when we're speaking about, fostering personal relationship, understanding your community and your actual patients, I'll be more willing to trust in the process if I trust in the individuals.
Thank you. And then our next audience question is, what are the panel's thoughts on the future of generative AI as an interactive diagnostic assistant, both in a clinical environment and for people at home? Are there ethical issues for medical practitioners relying on generative AI for diagnostic assistance?
Rich, I'm going to point that one to you first.
Yeah, that's a big question, and probably one of the most urgent ones. And I'll give it back to Ruth in a minute for how she's handling the potential threat of liability and obligation there, but as a delivery organization. But I think the short answer that I would say is I think it's foolish to suggest that AI is not going to help a lot. Where it helps is the place where I think we have to be really careful. There's going to be unbelievable questions of medical liability and those kind of things when it comes to, and responsibility when it comes to actually engaging the diagnostic or the therapeutic decision making with AI. And so what I see is organizations staying away from that as much as possible, other than the sort of proving out scenarios. There was an article yesterday in the paper that probably a lot of you guys saw that said that an AI tool beat a doctor, whatever beat means, in diagnosing things in an ER setting, right? And so what I would say to that is it doesn't just mean getting it right. There's an enormous amount of elements that go into that decision making. So like in my world, if we're automating workflow and we're taking off a lot of duplicative tasks off the backs of some of Ruth's folks, I think we're going to use AI for that tremendously. I think we're going to use AI to learn from all the data that's coming into a system like Carium, from human interaction, from device interaction, from all those kind of things. Can AI look at trends? Can AI look at levels? Can AI make suggestions on the back end? I think it's going to do all of that. But when you get right in the face of the patient and you say that the machines are going to make those diagnostic decisions, that's where I think is the furthest out and where all the care needs to be taken.
Yeah, I agree, Rich. Our position is, we're treading very, very carefully. I think there's a million things that we don't know and very few things that we do know. Silver Cross is participating in a consortium with other hospitals to really investigate AI and how it can be used, and what are the risks. One of the things it's actually in our strategic plan, long view. Again, we're spending this year into next year just learning as much as we can. It's an obligation on all of us as leaders to learn about it, to understand it, as Rich said, to understand the risks. And then as we learn things, again, implement change at a rate that people can tolerate, slowly. One of the things I worry greatly about in generative AI is bias, and I don't think we understand that at all. That to me is one of the biggest concerns.
Yeah, and I think it goes back to the security thing too, is
Yes.
the last thing I'll say, right? If so much of what Ronelle said is people have to know where their data is. They have to know whose hands it's in. They have to know what it's exposed to. So if you're going to suggest to that's the most scary of those scenarios, right? Is that you're going to set it in a large language model. And then you have to be able to explain what's it going to do with it? What's it going to learn from it? What's it going to say about it? Those are the things that people are going to care about. So we're going from that old chart room where people knew that all my health information is in that folder to I can put it everywhere and have all kinds of eyes on it. And AI is the ultimate example of that. And that's where you just have to ensure security, or you lose all the trust that Ruth talked about and Ronelle talked about in our earlier conversation. And if there's no trust, technology can't make a difference.
Right. I mean,
And
you
I
can
think that's
ruin
the
your
perfect-
reputation in 2 minutes, right? Whereas it took years and years and years to build up the reputation of being a trusted
Yes.
resource in your community.
Right. Carly, I know we're at time, and I know our audience still has more questions. I'll let you wrap up.
All right, great. Thank you again for all of your insight and for an excellent presentation. And thank you to Carium for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.
Thank you, Ronelle. Thank you, Ruth. Thank you, Rich. And thank you to our audience.
Thank you.
Thank you, everyone.